Hi, and welcome to a lecture on chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease, also referred to in short as COPD, is defined by the National Heart, Lung and Blood Institute and the World Health Organization as a disease state that is characterized by airflow limitation that is not fully reversible. The airflow limitation is usually both progressive and is associated with an abnormal inflammatory response of the lungs to noxious particles or gases. The American Thoracic Society definition is similar, where COPD is defined as a disease state characterized by the presence of airflow limitation owing to chronic bronchitis or emphysema. Stable chronic obstructive pulmonary disease. Bronchodilators, which are the mainstay of pharmacotherapy, decrease air trapping, improve the forced expiratory volume in 1 second, reduce symptoms such as dyspnea, and improve exercise capacity and the quality of life in both stable chronic obstructive pulmonary disease and in acute exacerbations of chronic obstructive pulmonary disease. Short-acting bronchodilators. Short-acting beta-2 agonists such as salbutamol or terbutaline are recommended for as-needed use in all stages of disease severity for immediate symptom relief. All short-acting beta-2 agonists have approximately equal efficacy, side effects, onset, and a duration of action of 4 to 6 hours. The short-acting anticholinergic ipratropium bromide has a slower onset of action in comparison to the inhaled beta-2 agonist, but a longer duration of action, say up to 8 hours. Here again, the recommended dose of 40 microgram of ipratropium bromide taken 3 to 4 times per day does not provide maximal bronchodilation, and therefore the dose may be doubled or tripled without notable side effects. Salbutamol and ipratropium used in combination produce greater and more sustained improvement in the forced expiratory volume in 1 second and a greater degree of bronchodilation compared with either of these drugs used alone. A single daily dose of tiotropium 18 microgram gives maximal anticholinergic activity for a full 24 hours. More sustained effects on pulmonary function, activity-related dyspnea, and quality of life are noted when compared to ipratropium. Glycopyrronium bromide is the first rapid-onset long-acting muscarinic antagonist as a dry powder inhaler, having a faster onset of action in comparison to tiotropium. The currently licensed dose is 50 microgram once daily. The combination of a long-acting muscarinic antagonist and a long-acting beta agonist is offered if disability persists despite monotherapy. The combination maximizes bronchodilation and lung deflation and is recommended in moderate to severe disease with persistent symptoms and infrequent exacerbations. Available data support the addition of roflumilast to bronchodilator therapy to reduce exacerbations, either before or in addition to the introduction of inhaled corticosteroids and long-acting beta agonist. Nausea, diarrhea, and weight loss were the most common adverse effects reported,